and welcome to this week's episode of The Dental Guys. I'm Wes, the Dental Guy.
And I'm John, the Dental Guy. And Wes, just before the show, we talk about how sometimes you just see some photos posted on the World Wide Web, and you just have to share them. And it's not pretty out there, Wes. People think it's pretty, but it's not pretty. The things that they're showing off, the things that they say, this is what let me tell you what's awesome. And they show you this thing and you just go, oh no, that's not good. Saw a picture of a lady just got her immediate implant temporaries post, looks like dual jaw hybrid surgery. And I would guarantee you there's no way she can ever get her lips together again. That's it for her. That's it. She's a mouth breather, obligate mouth breather. She has become an obligate mouth breather. It is amazing to me. There's one thing about showing beautiful cases on social media, like beautiful, where you're like, oh man, that's unattainable. That's so awesome. There are people that show those cases and make you feel inadequate as a dentist. And then right after that on the feed comes this. And you go, you know what? We're going to be okay. But you realize it's bad out there. It's kind of bad out there sometimes, Wes. It just is. And it's just right before the show, I was like, this is my, close to home. I'll just say it that way. Close to home. It can hit close to home
sometimes with these things. I mean, we've been there. Yeah. You try it in, and it's not right. And when it doesn't go right on those days, whenever you're doing this milled printed type thing with, immediate hybrids, really, you got to have that backup plan. And there's just so much.
As our guest will say today, it's time to put on your brown pants. I remember him saying that. So
before we get
but
to
that's
that,
true though.
It's good.
That's right. Before we get to that, let's give some thanks and some love to the sponsors that make this show happen. First of all, one you may have heard of. If you haven't, you need to check them out. The Dental Crafters Network, longtime sponsor of the Dental Guys, built on a foundation of unwavering dedication and respect. The Dental Crafters Network is a family-owned dental laboratory with 30-plus years of history, enriching the customer experience through their core values, responsiveness, versatility, and trust. They collaborate with you to meet your patients' unique needs. Experience the difference and receive 10% off your first case when you tell them the Dental Guys sent you. Call the Dental Crafters Network today at 800-472-8302 or visit dentalcrafters.net. Thanks to the Dental Crafters Network.
Yeah. And by Restorative Driven Implants. Hey, place implants on live patients in the United States after taking a comprehensive series of courses that provide you education, not just with healed ridge implants, immediate extraction, immediate placement implants, not just with that, but fully guided precision surgery. Safety is key with implant surgery, and one of the things that Restorative Driven Implants does to systematize and create predictability and systems to protect your patients is we employ at Restorative Driven Implants, teaching you fully guided, CT-guided surgery. It is amazing. Surgical principles, as well as immediate extraction, immediate placement, all the healed ridge. It's amazing. Surgery in the United States, it's really unheard of. There are places around, but there's no value right now greater than Restorative Driven Implants. So if you're interested in starting your implant journey, head over to restorativedrivenimplants.com right now and make sure you tell them the Dental Guy sent you. Call 715-207-6587 for Restorative Driven Implants. John?
And last but not least, thank you to Spear Education for partnering with the Dental Guys. We believe in what Spear's doing. As you know, that if you followed our podcast over the years, you know that they're doing things right. And we followed directly down that path over the years. It's literally changed our practices in a way, really changed our lives. The way we think about things, about dentistry, the perspective of what dentistry can do, having more fun, in the dental practice on a daily basis. And so thanks to Spear for offering 20% off of a workshop, which is no small thing. So head over to the Dental Guys landing page with Spear, and they'll be, I'm excited for you to start your journey with Spear Education. Thanks to them for being a partner with the Dental Guys.
John Texter. Hey, listen, are you texting the Dental Guys? I've been getting a lot of texts. Many of them I reply to and we don't talk about on the show, but this one was great. It was just a blanketed statement just after we had talked about something via text. 865-544-8954. Text the Dental Guys. Craniofacial anatomical determinants of pediatric sleep disordered breathing, a comprehensive review. Interesting. Came out, first published November 18th, 2024. You guys know we are very much interested in the craniofacial development of our pediatric patients. In fact, John and I both are proponents of early intervention orthodontic expansion therapy, whether it's through rapid palatal expansion, MSE devices. But here is an interesting article that was published in the Journal of Prosthodontics, John. I mean, this is crossing lines that we never thought were going to cross as far as this type of thing. And just briefly, if you see this on your screen, you know, what this went through was some amazing things. And it turns out the conclusions are exactly what John and I have been talking about for the last almost 7-8 years, which is early diagnosis and intervention are critical in managing PSDB. Dentists, through screening and early treatment, can significantly influence craniofacial growth and health outcomes. A multidisciplinary approach is essential for effective management, improving the quality of life and long-term health of affected children. Now, listen, John, what I want to talk about is not this article, because this article is like, hey, it's right up our alley. We know that. But interestingly enough, they mention the multidisciplinary approach, John. And we just got done having a conversation about interdisciplinary teams. And the one key member to the team that you really need to have is an orthodontist. And coming up on the next episode of the Dental Guys, we're going to have Jeff and Greg from Spear Education talk a little bit about some of these things and that interdisciplinary team. John, the orthodontist, how important is it to us today?
Well, it's really critical to moving into the next phase of interdisciplinary care. The orthodontist is sort of the gatekeeper to you as a general practitioner being able to move past just doing basic dentistry. The orthodontist that understands growth and development and understands even the most basic of the advanced techniques, I'm saying the most basic of the advanced techniques. Let me just repeat that. The most basic of the advanced techniques. We don't need to have a superstar. You know, this article you cited is written by Audrey Yoon. And Audrey Yoon is the director at Stanford at the Sleep Medicine Center. She's a professor there.
She knows stuff.
And also teaches orthodontics at UOP. And I've got the opportunity this summer to get to hang out with her a little bit and to talk about the stuff they're doing at Stanford. They're doing the most advanced of the most advanced. So you don't need Audrey Yoon to be your orthodontist. You just need somebody that understands this article and is willing to move into the most basic of advanced. And if you have that, you literally can do anything you want, almost anything you want, that can change people's lives. And I'm talking about just from a restorative standpoint, from a wear standpoint.
Oh,
and then
incredible.
As we move into the airway side, it's even more. So I just think that as you hear what Jeff and Greg have to say in the next episode that we'll be releasing down the road, and as you read articles like this, you start to see that we really, as general practitioners, really any other specialty, we are looking to orthodontics to essentially lead the way, because they can allow us to do things that we otherwise just couldn't do without them. So let's come on, Ortho. Let's bring it. Bring it. We need you.
Dr. Patel, graduate of Restorative Driven Implants, for sending that article over to the Dental Guys. Shout out to you, graduate. Hope you're doing great. Appreciate you guys for sending text 865-544-8954. Send the Dental Guys a text. Maybe you'll get mentioned on the Dental Guys. Thanks for Geeks Corner tonight, John, and highlighting how important orthodontics in children and early intervention especially. It's a game changer. Well, without further ado, we're going to talk about something that's near and dear to our heart tonight. We would love to bring one of our favorite people on the podcast, Dr. Jan Bublik. Welcome to the podcast. Welcome to the Dental Guys. Thank you so much for coming on and talking shop with us. We love talking about science, and you are most definitely a science. You've been published. You've taught in the implant realm. You're teaching at Restorative Driven Implants. With John and I, you sat down across the table and helped formulate some of the curriculum years ago at Restorative Driven Implants, and since have formed the master classes there with Dr. Kruger, where people are taking it to the next level. So welcome to the show, Dr. Bublik.
Thank you, guys. Appreciate you having me in here. And yes, shout out to you guys for bringing the wealth of next level education to the people who are willing to listen.
Yeah. Oh man, Jan, we're so glad to have you with us. It's been a long time. We've all known each other, and a lot of things we've gotten to see and do together. I want, for those who don't know who Jan is, let's go through a little bit about who you are. What do you do? What are you passionate about? Kind of what's your little bit about your journey and what you're doing now?
Yeah, thanks. So, I've been practicing dentistry. Practicing. I'm not perfect, so I'm keep practicing since basically 1993 when I started in a dental school. Graduated 1997 from dental school, 98 from medical school in Olomouc, which is a city in Czech Republic. The university there has been established in 1386. So it's been around for a while. I finished my dental residency or dental alveolar surgery residency in Czechoslovakia, and in 2000 I was invited to the University of Rochester, Eastman School of Dentistry in Rochester, New York. And I was in Rochester. I graduated advanced education in general dentistry. That's where we kind of learned all the general dentistry pathways to success. And I was an assistant professor there until 2006. Started my own office in a city near Rochester, where I was focusing mostly. It was a general dental office, but vast majority of my clients were. I did a lot of interceptive orthodontics, TMJ, and orofacial pain, as well as oral surgery and dental implantology. And in 2010, my wife decided it's time to move back to Wisconsin. So moved to Wisconsin and started to work with different people. And one day I sent an implant case to person dear our hearts. Brad Slominski at Dental Crafters, and the next day I got a phone call and said, "Hey, I just want to know who placed your implants." I was like, "Well, it was me. Why? Is there anything wrong?" He's like, "No, nothing. That's the problem. There's nothing wrong with them. So I need to meet you." And and that time, 2 years later, or maybe even less than that, I met Wes. In Wisconsin, and pretty much the rest is history. I've been involved with RDI since basically 2014. And as Wes mentioned, yes, we did bring the master series where we teach advanced procedures. Mostly, it starts with complications. We have one series on complications. We have a series on sinus augmentations and how to properly decide which approach to use. Soft tissue, soft tissue management, and horizontal and vertical ridge augmentations, which is a part of a master series of RDI. Currently, I have a practice in central Wisconsin where we are focusing on implantology, and from grafting to implant placement and restoring, and photogrammetry, which is our heart when we have such a great cooperation with the dental crafters, which is really, I'm lucky to have them right in my backyard. So I've been working like that for close to 25 years, and one small thing, I'm always learning myself. So I'm finishing my PhD in dental implantology in my alma mater in Czech Republic. So yeah, I've been around town.
Very cool. I love to hear that, and I think that is, that amount of experience in the dental implant world is, it's somewhat rare. We're seeing that in terms of people that are teaching. It's interesting that we see a lot of younger people, that have been in implant dentistry maybe 10 years, 5 years or less, that are doing a lot of teaching. And for a while there were sort of these, it was normal to have a lot of people that were in their, say, 60s and maybe even 70s teaching implant dentistry, that were some of the original innovators. And but what it seemed like that there was somewhat of a time, and I always give Wes a lot of credit when we talk about this, because there was a time Wes and I did a lecture together, and it was really his idea to talk about this. We talked about implants in the 90s. There was a time, the 1990s was a big decade for implant dentistry. It was when we had some of these giants, such as Carl Misch as an example, who wrote a super influential book that framed our understanding of maybe some, quote, modern aspects of implant dentistry at the time. It really was. But there seems to be one topic that if you talk maybe to somebody who's been doing it longer than a certain time, that seems to be for some still a little bit taboo, still a little bit risky. And that's the topic of immediate implant placement. So I really want to dive a little bit deeper into immediate implant placement, because we know it's not new. We know it's not maybe from the 90s as much, but it's not new. And yet we still have all the way from dental implant residencies all the way up into surgeons and specialists and people that have been doing implant dentistry for a long time, like you, Jan, have been doing it for 20 years, 25 years. What is it about immediate implants that has made it something that maybe people are worried about or concerned about? Why has this been a thing that's been controversial?
Yeah, so what I see as a disadvantage when you're talking about implantology, heel ridge, immediate, I feel like disadvantage is that there is not a clear residency or education in implantology, that it's being taught by oral surgeons, in oral surgery residencies. And, it's being taught in some pros residencies, which, I totally respect. It's being taught in a perio residencies. And there are two aspects. If you think about it, who is teaching that? Those people who are teaching, dental implants, many of them were taught in the 90s, and I've been through Mish curriculum, in early 2000s, and he always said, why would you hurry to place an implant into post-extraction socket when you can wait 3 months and then you just have a reassurance, and I feel that there is a possibility that everybody wants to be just so precise and have the highest success and don't do anything risky. And I just don't think there is enough research which would people which would make people say, hey, I don't know if the word risky is really a good approach to that. What does it mean, risky? If you feel that the implant, all what you need is for the implant to heal, then place it into a post-extraction socket or not. The implant will heal. But nowadays, that's just not enough. The next level of implantology is the soft tissue, right? So that's where the immediate implant placement, I'm not talking about restoration or function, but those are three different things. But that's where the immediate implant placement with correct, supra structure can be so much more advantageous. And I feel that if you're talking, for example, about oral surgeon, last time they were, placing an, I don't know, abutment, which is, they had to form or even order, maybe that was in a dental school. They're more looking at the surgical part. If I would feel that maybe the periodontists have a better understanding of the soft tissue, so you may find more approach, more, it would be easier for them to kind of say, okay, let's just try that and support the soft tissue. But if it's, if, for example, something, goes wrong, then it's like, it's immediate, it will never work out. And I just don't think that's right. I feel that there is the comprehensive approach is missing to that, to understanding of those techniques. In my office, 80% of implants are immediate, and I don't have any more failures than anybody else. It is 96% success. It truly is, even more.
Yeah, I think the thing that is interesting here is that the literature backs up, what we're seeing, in clinical practice. And it's not even new literature. I'm going to put a piece of literature that I've used for years. It's a very good study. In fact, the study is about immediate extraction, immediate placement into extraction sites with periapical lesions. Now, we're not talking about pus here. We're talking about things that you see on a radiograph. And then, of course, this is a retrospective study, but it's a good chart review that's published in the Journal of Maxillofacial Surgery in 2011. Now, the interesting thing here is that the results showed that of 922 implants, 285 were placed into sockets with periapical radiolucency. The success rate of the study was found that study group was 97.5%, whereas the success rate of the control group, those placed in fresh extraction sockets without, was 98.7. The difference was found not to be significant. Follow-up time. This is key. Almost 20 months with a maximum of 93 months and a minimum of 3 months. The interesting thing is that here we see, even with some situations where maybe everything isn't going for us, we see success. And I think it's important to realize, if you're listening to this, is that there's some kind of angst still in the dental community that immediates don't work as well. When, immediates have been shown time after time after time to be just as successful as a healed ridge. And this idea that, John, that you and I face that, oh man, there is some angst about it.
Mm-hmm.
Why are we
Yeah.
feeling angst, John? I mean, what is it about the healing of an immediate
Mm-hmm.
extraction socket that makes people feel, and that's what we're talking about. We're talking about feel. We're not talking about science. What is it about it? What are the
Yeah. I
what?
can. Yeah. It's anecdotally, when we teach at Lac de Flambeau, okay,
Mm-hmm.
and we take teeth out, it happened every weekend, at least once. It happened when I hear from, seasoned dentists who are taking our course at RDI. I hear, oh man, I've never seen so much stuff coming out of the post-extraction socket. And those are usually endodontically treated teeth, and they take the teeth out and then they are kind of ready to put an implant. I was like, hold on. You have to treat the socket differently. You don't have that when you have a healed ridge. You are presented with, one type of bone or another. You go according to your protocol and you're done with that. But I believe that people are not taught properly how to debride the socket, how to prepare that. That's why we have, some studies suggest that there is a higher failure in implants which are placed into post extraction sockets. I've seen studies which claim that there are some, rare bacteria and some helicobacter in the bone. And I'm like, I really would love to see more than one study claiming that. If you can repeat it and it can be, proven, okay, I'll take it. But to be like worried that this is something, still experimental and new, I just don't I just don't buy it. It's so much more advantageous to put it into the fresh extraction socket, as long as you know how to properly approach that socket. I think that's where
Well,
it's most of that.
let's talk about and I want to get into a little bit about maybe how to think about some of the things that we would think about with who is a candidate for immediates a little bit, because this obviously,
Mm-hmm.
we don't want to, we're not teaching surgery tonight, right? But we want to talk
Right.
about, I want to maybe take it one step further and ask you maybe what might be a controversial question. It's really not, but why are immediates better? What makes an immediate implant better than a healed ridge placement or a delayed placement? So we take a tooth out. We take a tooth out and we don't place an immediate implant. If it's an appropriate time that we could, which we'll get into.
Mm-hmm.
But if we could place an immediate, but we choose not to because we're worried or nervous or whatever reason, we're not trained, whatever it is, what is it that we lose aesthetically, from a biological standpoint, and what are we up against differently? Because for years the thought was, hey, we'll just come back, we'll place it delayed, we'll
Mm-hmm.
give it however many months to heal, and then you would see people like Uli Grunder, and they would say, well, we'll do 17 regenerative surgeries in order to get
Yeah.
back. Now, I'm giving the punchline there, but what is it
Yeah.
that we lose by not placing an immediate that should make a huge difference to us from an outcome standpoint?
Yeah. Well, John, ask yourself, what is it you're looking at as a patient? What do you want to see? Do you want to see the implant? No. You want to see a beautiful architecture of the natural tooth and the beautiful gingival architecture of the implant. And I strongly believe, and it's been proven, the moment you, I don't know, cut the papilla or just let the papilla, heal, the gingival architecture is gone. You are losing the aesthetics. You're losing the support, which you could be supporting during the, immediate implant placement. You're losing the support of the, I don't know, your, canine eminence. You're losing the opportunity to make it aesthetically like, wow. I think that's what you're losing.
Yeah. Yeah. I mean,
Is
when
that
a
where you were
socket,
going?
you know, yeah, absolutely. I mean, and just from a biology standpoint, right? I mean, we know that if we extract a tooth and we do not place an immediate implant, we see facial bony wall collapse, right? And we
Sure.
see a change in the final restoration as far as, we know from what, for instance, Tarnow and Shu published when we talk about dual zone, right? We've all talked about that forever
Hmm.
and ever. That, if you compare a socket that's just grafted, or let to just heal with no implant placement, and you look at what happens at the, say 4 or 5 millimeters apical to the free gingival margin, that huge indentation that we see, this
Hmm.
huge depression that we see, even above the restoration, let alone at the level of the implant. And how, like you say, we lose this gingival architecture. And Jan, talk about how hard is it to regain that gingival architecture that you lose. Let's say we're talking about an area that we're going to place two adjacent implants. We have
Hmm.
two failing teeth. We have two adjacent implants that we're thinking about placing there. If you extract those teeth, do you feel, how predictable is it to be able to achieve a papilla, between these two adjacent implants, should we choose to go with like a delayed placement versus an immediate placement?
So it is really tough to create or have the papilla which is there, to remain. That's really hard. To be perfectly fair, you will lose some of that, interdental papilla between two implants within about 24 to 36 months, even if you place the implants immediately. There are some techniques like a socket shield you guys been talking about, where there is a chance that you delay that that papilla, the recession or depression, but you have a much higher option, a much higher chance to keep the papilla which is in there if you place the implant immediately into the properly guided post extraction socket, and you support that papilla and the crestal bone with the properly planned abutment. I'm not talking about stock abutment. I'm talking about abutments which you create or you make with your laboratory.
So if it's not failure that we're worried about, let's say we can put that to sleep for a moment. Okay, so
Mm-hmm.
let's just say, for the sake of this discussion, that you can convince someone that who's placed implants before,
Mm-hmm.
okay, that failure is not the problem. So then what are the challenges in learning how to place implants immediately? What are some things that, and I'm not even going to talk about the new implant placer, because I don't think your first new implant that you place should be an immediate,
Should be.
right? I think we can all
That's
agree
right.
that that's not your first implant. But if you're an experienced placer and you've placed lots of healed ridge implants, what are some of the things that are a little bit, that are going to be some things you have to learn to
Mm-hmm.
do differently with immediate placement?
Absolutely. So, as we used to, we used to have a panoramic X-ray and then PAs for healed ridges. That was okay. For immediates, and especially immediates in aesthetic zone, you definitely need some serious good planning. You need a 3D understanding of your anatomy. You absolutely need that. And if you want to get an advantage of your immediate placed implants with respect to a soft tissue architecture, you will need to have some sort of custom abutment on that immediately placed implant. You will need some sort of support so that the soft tissue does not collapse. Uh, Another thing which you definitely will need is a good atraumatic extraction. That's number 2. And number 3, you need to know how to debride the socket properly so that it becomes your friend and not your enemy. You can't leave periodontal fibers or fibrotic fibers, after long, when people leave a root canal treated tooth in there for a long time. So those are things you need to understand. You need to understand how healthy socket looks like. You can't put it into socket which is either fibrotic, destroyed, or periapical pathology which actually is active. You can't do that. So that's what I would say. 3D, understanding the 3D situation, however, is number 1 thing.
Yeah, there's a lot to unpack there. The thing I think where I'd like to go down, especially in the educational realm, is this idea of atraumatic extraction technique.
Mm-hmm.
It is undertaught.
Absolutely.
It is a term
Absolutely.
that just kind of gets misused per se. I mean, there's, the idea that surgery is not traumatic is kind of a misnomer, but let's talk a little bit about that, because it's very difficult to retrain the brain and move away from doing certain things when it comes to extractions, and then following up that same day or within 3 weeks and placing the immediate implant in the fresh socket.
Sure.
What are some of the untrained things that have to happen? You have to actually untrain the mind, as you've talked about in your lecture.
Yeah. You need, as Master Yoda says, you need to unlearn what you have learned.
That's it. That's what I wanted to hear.
Yeah. I remember, Wes, in, I want to say 2015 or 16, you stood up in front of the first class of RDI, and I think you said something to the nature, everybody raise your hand and swear you will never, ever raise a flap. From now on, you will never raise a flap when taking a tooth out. And I think that's, when we talk about atraumatic tooth extraction, I believe in people's mind is like traumatic means you raise a flap and drill a bone away.
Right.
And atraumatic means you don't do that. And that's really, that's really the basic of it. Like, where is always the problem? The problem always lies in a buccal plate, right? We are trying to either maintain the buccal plate or obtain with some techniques. You can do a hard tissue technique, soft tissue techniques, where you can fake, the presence of buccal plate, for a while. But that's basically what we are trying so hard to protect. It's the buccal bone. It's the buccal plate. And that's where I think that, the misnomer of atraumatic extraction, you're right. I mean, there is no such a thing as a painless dentist, so there is no such a thing as a atraumatic extraction. We don't take Hippocratic oath for a reason, because we do cause harm, but we are trying to kind of make sure that we cause as little harm as possible.
Let's talk about the differences in, you've covered really well, some of the things that you have to think about. We can't take out teeth the way we learned in dental school. That's clear. Right. We've got to be, if we're doing immediates, we have to be thinking this has to be a site for an implant. That makes great sense. But even just from a placement standpoint itself, when you have somebody who is used to placing an implant as if it's placing a screw into a piece of wood, where we have a solid piece of wood, and then now we have a socket, and the root is not always going the direction that you want the implant to go. And the socket is not always the size, or rarely the size, of the implant. So let's not minimize the challenges with that, because I think that it is easy sometimes as we look at the surgery involved in implant placement. And I think there are a lot of surgeons that are very comfortable placing into healed ridges because there are very few variables relatively.
Yeah.
So talk about some of what goes into thinking a little bit more. We can't be on autopilot placing an immediate implant. In some ways we can be, in some ways more, when we're placing into a healed ridge. What are some of the differences, and how do you, as you're training people to think about immediate implant placement, overcome or maybe just train people how to think differently? Because there are some things that people start to bring up. They start to say, well, what if the root's going the wrong direction? Or what if the socket's too big? Or are you saying I actually have to measure things when I'm placing immediates? These are let's talk about this.
Yeah.
Let's take it to a little
Yeah.
bit deeper level here. Let's
Yeah.
be honest that immediates aren't easy, and that's okay. We're not supposed to be doing dentistry because it's easy. But can it be predictable? And what's the difference? And what are some of the
Yeah.
things that you kind of have to overcome as you're training people that are maybe comfortable with healed ridge and you're trying to introduce them to immediates? And what are some things you start talking about?
Sure. So number one thing, there's a reason why, we at RDI don't start with immediates, but we start with a socket grafting, and the healing. Number one is the healing, starting with the proper patient selection, obviously, but if you're not comfortable, or if your socket grafts are not, healing the way how you would think that they should be, maybe immediate implant placement where you need to have a grafting alongside with the implant placement, maybe that you should probably wait with that. So there is a grafting which is absolutely necessary. You should not leave the the space between the socket wall with the lamina dura and your implant. You cannot leave that empty. That's been debunked. That you could 2 millimeter. That's okay. It's not okay. The other thing is, as you are drilling into the bone with a healed ridge, most of the time, you have one type of bone. Well, if you're drilling into post-extraction socket, don't forget, you have a cortical bone. Okay, it's maybe only 0.5 millimeters, but it is a cortical bone. That cortical bone in your lamina dura has to be penetrated and then go into a cancellous bone. So there is, there is a trouble many times if people are not using guides or not using the guides properly, they can be misaligned. The placement may be misaligned, and as exactly as you said, many times we don't have the proper angulation of the previous tooth, and if we were to place the implant, it would go off angle. So that's why the 3D planning is so much more important, because you need to know, and most of the time you do. I have a cone beam CT. I have I can put my implant on the in the co-diagnostics in there, and I can also put my crown. Is that crown going to be, screw retained? Is going to be cement retained? You need to, and you basically know all of these things. So it's not just, I'm going to put the implant in there, call it a day. And then when the patient comes, I decide, during a second stage surgery. So you're 100% correct. It is more involved. That does not mean that it's less predictable. I believe, on the contrary, you have more control over things. That's kind of how I'm looking at. What do you guys think?
Joe Kahn published a great paper. He was the principal investigator on the sagittal root projection of anterior implants. I'll bring just the classification up on the screen as we're looking here. Hey, listen, if you pull your car off the road and pull up the YouTube version of this and check out Joe Kahn's, sagittal root projection paper, but fantastic paper on the position of roots in using CTs. And so basically what Dr. Kahn does is he goes through and creates risk factors based on each classification. There happens to be 4. So if you're looking at this here, you can take a look at this. Academy of Osseointegration published this in JOMI back in 2011. And so here we go again with,
Mm-hmm.
something that, I mean, here we are 13, 14 years later,
Yeah.
talking about some of the same things. And probably from what I can tell, only 30, maybe to 40% of placers right now in the United States are considered to be doing immediates, which it blows my mind
Yeah.
because the opportunity to learn something like this that has been around really since I graduated dental school in 2003. And even before that, there were things going on moving in this direction because we understand more about healing dynamics. Now, I mean, we're coming up with some interesting implant designs, and the biggest design that kind of was the game changer in this. And Jan, I want you to talk a little bit about this because I know you've used, just like us, different types of designs of
Mm-hmm.
implants. But the game changer was the root formed implant, which is basically a tapered style implant that allows us to avoid anatomy when we're doing immediates and put the implant in the right position depending on the sagittal root projection, the furcation. But there's different implant designs now that allow us to place immediates appropriately. Talk a little bit about design aspects right now in the implant field and really what shouldn't we be using, right? Start with that. What should and shouldn't we be using right now when thinking about a dental implant that we're going to place immediately?
Mm-hmm. So with respect to immediates, I have not, to be perfectly honest, seen too many or none, immediately placed implant, which would be a tissue level implant. That kind of defeats the purpose. You want to have implants which are at the crest or subcrestal implants. And what's the difference? Well, the difference is the connection, right? It's whether or not that connection in the future will be having micro movements, or what's the where's the force going to be transmitted onto the implant? Is it on the implant or is it inside of the implant? So deep conical connection of the implant, as argon or bicon has, and now BioHorizon is coming up with came one, the Strawmans came with one. Deep conical connections are definitely preferable because they are designed to be placed, subcrestally. So that's kind of number one thing. Number two, what I believe I've heard, and I don't believe that's necessarily the case. People always are saying, well, you can't leave exposed metal because it's gonna feel like a foreign body. Well, vast majority of our implants have exposed metal when they heal. So, I don't see that much of a, this logic just doesn't really translate. And then, you did talk about root form implants, tapered root form implants, and I believe the aggressive threads. And nowadays, where you have a lot of mechanical stability while you are waiting for the biological stability to take over, that's the number. That's the next thing, which is important for the immediate placed implants, because it is true, you don't have that much of a intimate contact with the surrounding bone, and you have to wait for your body to create with destruction and apposition of the graft and new bone. You have to wait for the body to create that.
Well, I think that's, it definitely, I think a lot you kind of alluded to this, that manufacturers have changed many things about implants,
Mm-hmm.
design wise. And if you look at the direction things are going, many of them have started to look similar as a
Yeah.
result of potentially what we are asking for immediate placement, which is, again, more stability, better connections, conical connections, subcrestal placement. roughened surfaces to the top of the
Mm-hmm.
implant, different ways to try to control any exposure of the implant, depending on how rough or smooth the surface is. All these things really have been driven by the innovations have been driven largely by immediate implant placement. And that's another thing that kind of just makes it interesting to me that sometimes you still have people saying, oh goodness, I'm worried about this. Because we know that this is when manufacturers are looking to their biggest growth is in immediates. And
Mm-hmm.
so I think, as we see that, we shouldn't be worried about immediates, but I think based on what you're saying, we certainly need to understand the protocols, understand what is the right way to do this, because there are more pitfalls to immediates. We kind of started off the conversation saying, well, why are people so worried about immediates? Come on, they work. Yeah. But I think as we've talked more, there are things you have to pay attention to. You have to be on your game. And I think as we sort of start kind of taking this in for a soft landing, Jan being a pilot, we let's talk about what if you obviously we know there's no secret. People know you teach this, right? And we want to be
Mm-hmm.
we know that we're proud of that. But so where where should people go to learn about immediate implant placement? And we know you're going to say where you teach, of course, and you should, but why? Like what? Why would you say that? Like because everybody says, oh, come to this place, learn how to place implants. Come to this place, learn how to place immediates. I've seen some crazy stuff out there when it comes to what's actually going on. And I'm
Mm-hmm.
not just talking about the actual techniques being taught, because that's what I want to focus on. I don't want to throw shade at how people do
Yeah.
things necessarily behind the scenes. But let's just talk about the brass tacks. Let's talk about what is it about what you're teaching that is different about what other groups are teaching, and why should people go there, and why should they choose that? Because there's so many people out there saying, man, I'll teach you how to put an implant into every socket. So Jan,
Yeah,
talk about
and
what's different.
before you answer that,
Yeah.
I am frustrated about this. I'm more frustrated, and I think John is now than I was years ago, because there's so many people that are saying things, and it's a lot of noise, and it doesn't follow any rhyme or reason. And
Mhm.
it's frustrating for young dentists who are coming out and taking these courses
Yeah.
at a young age, younger than they ever have. We've seen it
Mm-hmm.
in courses, we've seen it at Spear Education, and how important it is to find a place where the foundation can be set from the very beginning. We were talking to some clinical educators recently, and they were really concerned that dentists get ingrained into bad habits.
Mm-hmm.
And these bad habits are hard to overcome for fear of failure, from the bad habit. And it's like we're so strong-holded in some of these beliefs. And what happens at a lot of these, educational venues, and whether it's a weekend course or just something you see somewhere else. And again, I don't want to cast shade on anything specifically, but just as a whole, it is very, very frustrating what we're seeing. And John and I travel around and see a lot. Jan, what makes what you've been a part of from the very beginning, even at the University of Rochester, and and how you've moved through your practice and what's made you successful? You track your success rate, your publishing success rates. My goodness, and so I want to hear about that.
So, number one thing is, if something doesn't feel right, don't just listen to what people say. Oh, you have to do it. It works in my hands. Just take a really step back and think where you are at right now, what you can do, what you can learn, what you can get better in, and where you talk to your friends, where you get a good education. We at RDI have really followed this program of, first of all, has it been proven in research what we are talking about? And what, that's what we always ask, right? We have a consensus weekend. What do we need to change this, next? Is it still true what we've been teaching this last,
Wait a minute.
2-3 years?
Let's just stop for just a second.
Yeah.
We had a consensus weekend. What did that entail? What was that?
So we got together with all the RDI instructors, and
Like 15
we had
of them, right? Yeah.
Yeah, like 15 of them. And we went, close to, not all of them, but close to slide by slide. Hey, is this still true? For example, pre-medication protocol, is this still hold? What does the ICOI say? What does the AO say? Here is the latest article from the ICOI magazine. Okay, is this still true? So we fixed that. We follow that protocol. Next thing was, what type of materials, for suturing are we using? What type of membranes, what type of grafts, and things. We ask everybody who is in there, hey, because our people, our faculties, they take their own classes too. So it's like, what did you hear? What do you feel is, what was surprising, what was new? We look at it, check it, can we accept it? Yes. And kind of go from there. So we are bringing things together, we are pulling things together for to make sure that what we teach is concise, it's true, we don't make stuff up, and it's backed up. It's backed up by research. Now, when we teach that, we also provide the attendees with the opportunity to place their implants, on patients at here at the Lac de Flambeau. Those are which is in northern Wisconsin. Those are patients. Many of them are my patients from my office. Many of them are their patients. We need to follow up these patients. We need to they are our friends in our community. They live with us, and like that's why we get so many more. Hey, I've heard my neighbor had this amazing experience, and at your education facility, and now I want an implant as well. Like, we are actually proud that we bring some people, some attendees who just like are blown away how amazing this is, the camaraderie, and the fact that and put some pictures like, hey, this is what you guys did 3 months ago, look at that. On our closed website, which is for faculty and for people who went through RDI. So we follow up, those cases. So I feel that's where our advantage is. That's
doing it the right way, clearly, and that's one of the things that we don't many times. We see courses, including people close to me that have been to courses where you're just placing one of 10 implants in an edentulated maxilla, in somebody who you never met, no planning, no guiding, who knows what kind of follow-up. And you know what, that's one issue we can debate, but I care more about the real world aspect of that. Like, if you're coming into implant placement, that's probably not who you're doing your first 100 cases on, is putting 20 implants in somebody. You're probably going to be doing it in a 1 or a 2 implant situation, maybe an immediate, probably a lot of healed ridge, probably some guiding, something that's been planned, something that's actually going to be restored by you. And so if that's not what you're learning in your course, then I have a hard time transitioning. People talk about failure to start all the time, right? You go to these courses and you have a failure to actually start. You don't implement
failure
it.
To launch.
And I think with dental implants, it's just this issue because it's not real world. It's not something you can actually see translating into your own practice. And so I definitely appreciate that approach. And of course, the dental guys, obviously, the research-based approach, consensus weekend, I love it. Having, discussions, never being satisfied with what we think we know. I think that's awesome.
Right.
And, I think that having this conversation, if it doesn't come through, if you're listening to this, that this is the kind of people that you want to be around if you're planning on, trying to investigate whether implants are something to implement into your practice. Obviously, this is the kind of thing that you want to be involved with, and I think it's been great to just get to talk to you and hear that passion
Jan,
come through.
We've been asking some of our guests this year, because kind of our theme for the year has been what's messing with us. And it doesn't have to be dentistry, but it could be something that's confounding the mind. Like, what's messing with you in 2024 and going into 2025?
What's messing with me? It's coaching. Coaching. And I feel that there is with my young colleagues and also older colleagues, there is a lack of coaching, and many times I see lack of accepting an advice and trust and belief. I feel that from what I've seen, we are trying to coach young, budding implantologists. Okay, what's missing from that is a long-term relationship to your mentor, to your coach, and I feel that this is something what I want to give out to whoever is willing to listen, and to my friends, because me and people like me, we have a lot of crystallized intelligence, and which came over the years. I've drank wine with Carl Misch 20 years ago, and the stories like what I've heard from him, and I feel like there was a mentor when Misch Institute was just beginning, so that's kind of where I see moving in 2025 to be more of a coach and mentor to people.
John, we've talked about this.
Yep.
I'm going to flash on the screen for those that, it just seems like it just keeps coming up, John. And it's the death of expertise.
Yeah.
I challenge you to read the book. It's incredible.
Yep. When I read this book, I heard about it on NPR. I was listening to, a quick interview about a presidential candidate. And one of the presidential candidates earlier this year said, "I promise that I'll listen to the experts." That was one of the things that this person actually said. And I thought, wait a second, you actually have to say that these days? You actually have to say that, because there's a lot of people that don't. And so the author of this book was on and just saying, this is where we are these days, that you actually have to put yourself out there as one of your campaign promises, that you'll actually listen to experts. And that is where we're at in the teaching area, the teaching world these days, is that people like the feel of, I know something that like I figured it out. I don't need these experts. And often that is just as much a barrier. For a while, I really thought, and I know I'm ranting a little bit here, but I really thought it was generational, that there was a older generation that was just choosing to screw over the younger generation. And there is some of that. Basically not mentoring the younger folks. But there's also this weirdness going on where maybe generationally, maybe not generationally, I don't know, people are just kind of saying, you know what, I just know, I don't need that. I know, I figured it out on YouTube, or I did this thing and it worked, so now I know how to do it. And no core knowledge, no respect for 50 years of experience, or
Mhm.
I've written a textbook or 4, maybe you should listen to that person.
Yeah.
It's very interesting. And implant dentistry, I think, is one of the areas that it's the most dangerous to go in to placing permanent fixtures into people's faces, based upon what you think you know. So the idea of having, a structured curriculum that's vetted, that's based upon data.
Yeah.
But that's interesting, Jan, that you would say that that's the thing messing with you. I think it's messing with Wes and
Mhm.
I the
Big
most
time.
this year too. It's just, what do you do with that information? So Jan, thank you just so much for being with us this evening and
Thank you,
sharing
guys.
some of your knowledge and your experience and kind of what you're passionate about. And if you've been listening to this show and you've kind of learned some things, or it's piqued your interest, definitely, as Wes said at the beginning of the show, text us, let us know what you're thinking about, what's messing with you, whether it be with implant dentistry in general, anything going on in your life that's messing with you. It's interesting to us if you're passionate about it. Make sure that you tell your friends and colleagues about the Dental Guys, about what we're doing, about what we're about. Of course, we want you to like, share, and subscribe. Give us a 5-star review on Apple Podcasts. You can find us on all of your podcast channels, video, audio, Spotify, YouTube. We're all there. Tell us what's messing with you. What an interesting year it's been. So for Wes, for Jan, I'm John. It's great to be with you. We are the Dental Guys.